it is uncommon to have food allergy that presents only with respiratory symptoms. So runny noses, asthma exacerbations, in general, food allergy does not play a role. If food allergy plays a role, generally you have other symptoms. So your allergic rhinitis type patients, food allergy evaluation plays absolutely no role. The oral allergy syndrome, like I talked about, if you have birch pollen allergy and you eat pitted fruits, you get itching in your mouth, some swelling of the lips, mouth, and throat. Rarely do these progress to anaphylaxis. There's a small subset, probably under than 5%, that may. Avoidance of those foods is important. You can eat them cooked as you break down the allergens. When you see patients with suspected food allergy, the history is key. What was the story? Were the symptoms consistent with an IgE-mediated anaphylactic reaction? Were they consistent with eosinophilic esophagitis? What is it that you think is going on underneath? The second thing is you're looking for what foods you think are playing a role. You take a careful history. And my favorite question is, what are they eating now? So if they're eating a food, they're not having reactions, they don't have allergy to it. So I'm trying to rule out things. It's an all or nothing thing. If you're exposed to a sufficient amount, you should react every time you're exposed to it. So after you take a careful history, you think that the story is consistent with an IgE-mediated reaction. They have hives, they have respiratory symptoms. In some children with atopic dermatitis and eosinophilic esophagitis, you're worried that foods play a role. So you can go ahead and do testing in those cases. But again, you have to think it out beforehand and test to the most common food allergens. Why is that? The testing is not very good. So if you do typical food allergy testing by skin testing or RAS testing and it's negative, it has a very good negative predictive value. You don't have food allergy, typical food allergy. If it's positive, the positive predictive value is extremely poor. It's on the order of 40%. And if you're not judicious in who you screen, it's actually, the positive predictive value is even lower than that. So when you do these tests, all you're getting is a positive result. It doesn't mean that there's any relevance whatsoever to that patient. There's no role for intradermal testing whatsoever in food allergy. It's dangerous. For things like fruits and vegetables, again, for those rare patients that have a very convincing story of allergy to something else, you have to be cautious because typical allergy testing may be falsely negative. And in those cases, you bring in fresh fruits or vegetables and you prick the fresh fruit and you prick the skin. And a lot of times you pick up those rare patients. And in all cases, the gold standard is the food challenge. So you get positive results, you're not sure what they make, your RAS levels are low. The only way to sort it out is to give the food you're concerned about. And we do it in a very controlled setting where they come into the clinic, we give them very small amounts, gradually increase, and follow them. And with widespread use of this testing, this is becoming more and more necessary because there are a lot of children who are diagnosed based on positive tests that probably aren't clinically relevant. So, food allergy skin testing and RAS testing plays a role, but you gotta have some idea what you're looking for. The symptoms have to be consistent. You have to break it down to only those foods that likely are playing a role, and it's all based on knowledge of these things that we've gone over. How do you treat it? Unfortunately, the only thing you can do is avoidance. So you're diagnosed with milk allergy, you have to avoid all sources of milk protein. It's incredibly difficult, and we put these families through an awful lot when we diagnose them with multiple food allergies. The families have to be meticulous to reading labels. Restaurants are problematic. You have to educate them about how to read labels. I use the Food Allergy Anaphylaxis Network in Fairfax a lot. They have a wonderful website. And the families need to know that this is important, and you're trying to prevent them from having severe anaphylactic reactions. The second thing is you have to provide them with emergency treatment. So if you're concerned that they're at risk for anaphylactic reactions with accidental exposure, they must have self-injectable epinephrine. More importantly, they have to know how to use it and when to use it, and we need to give them plans for how to use these things. What we're really looking for are ways to treat it, disease-modifying treatments. So avoidance is important, emergency treatment, but can we reverse the underlying problem with the immune system? And anti-IgE treatments, or Xolair, which are used for a subset of asthma patients now, is under study. You reduce the IgE level, including to peanut, and in one study with another product, you could raise the threshold for how much peanut you could ingest before you had a reaction. Not particularly beneficial, though. It's variable in terms of how patients respond, and it's not completely effective. Immunotherapy and vaccines are under study and are much more promising, including sublingual, where you put controlled levels of the food under the tongue. You know, so far things have looked promising, but we're really searching hard for ways to reverse the underlying problem with the immune system here. What is the natural history of food allergy? Well, most food allergy in the children we see is outgrown. So young children with food allergy, the families need to know that there's reason for optimism. We're telling you your child has milk allergy, but this will pass. And it's hard, but hopefully by 5 years of age, it'll be gone. Most children with milk, egg, soy, and wheat allergy lose their sensitivity by age 5. Allergy tests can remain positive even when they've outgrown it. And I'm going to come back to this in just 1 second. There are foods that are typically not outgrown, including peanuts, tree nuts, fish, and shellfish. So we say that these are outgrown. How do you know? So the general approach when you suspect a food allergy is, in my clinic, we do skin testing, and if it's positive, you diagnose it, and you let the family know they'll outgrow it. Every year thereafter, I obtain a blood test, and I want to see what the levels are on RAS testing. And we now know what those numbers mean. And when it gets to a level where I'm comfortable that they've outgrown it, we'll bring them in and challenge them to those foods. Every food is different. So they come back class 1 through 6. Those don't mean a whole lot. Foods like egg, very low levels are concerning. Foods like wheat, they have to be very high to be concerning. These patients need to be followed over time. And the families need to know they need regular follow-up. Peanut allergy in young children, so typically we say they're not outgrown. In adults, they're not. In young children, we now know about 20% of children outgrow peanut allergy. If you take the very young children with very low levels of peanut-specific IgE, it may actually be higher. And I've seen many patients who have been told that they'll have lifelong peanut allergy. I've seen them for other reasons, and sure enough, they've outgrown it. So again, reason for optimism there as well. Regular follow-up is necessary, but only in controlled settings with appropriate testing. So question 5, risk factors for fatal food-induced anaphylaxis include which of the following? Young age, old age, overuse of epinephrine, shellfish allergy, or asthma. So asthma, absolutely. And I'm going to go through other risk factors as well. So what is anaphylaxis? It's a systemic allergic reaction. It's incredibly difficult to define. On school forms, when you have to write down when to give epinephrine, it's incredibly difficult to define. It affects the body as a whole, and there's more than one system involved. So urticaria alone is not anaphylaxis. Urticaria and laryngeal edema, anaphylaxis. So you're looking for more than one system involved. And these can be fatal, including hypotension, gastrointestinal symptoms. Onset is generally acute. It's dramatic and you know it. Manifestations vary from mild to fatal reactions. The systems involved typically are skin, where you can get flushing, pruritus, urticaria, and angioedema. You can get upper airway symptoms, congestion, and rhinorrhea. Lower respiratory symptoms, including bronchospasm, shortness of breath, laryngeal edema. They can present with drooling at a young age. Gastrointestinal tract involvement, everything from oral pruritus to vomiting and cramping. And then what we really are concerned about is cardiovascular collapse with hypotension, shock, chest pain. And it's a combination of these that define anaphylaxis. It's not one of them alone. It's the acute nature of it after exposure to an inciting trigger. With foods, there have been registries where we've taken every child who's died from food allergy that's been reported and looked at the features. Is there any way of predicting which children or which patients are at particular risk for fatal reactions to food? There are about 150 deaths per year from food allergy reactions. They're usually caused by a known allergy. So these aren't sort of out of the blue, first time they ate a food, they had a fatal reaction. Most of these are patients that knew that they had an allergy. And when you look at these registries, almost all of these patients are adolescents or young adults. So they're in their teens or 20s. All of them have asthma. The only exception was a 2-year-old, but invariably they have asthma. Most of them have had anaphylaxis before.